Hey everybody, it's Karen Anderson here with Aortic Hope, and we have a very special live Q&A. Well, it's really special because it's really my last one of 2024, and it's a first for us here. So before we get started, I'm going to ask you just to click that like button, click the subscribe button, click the little bell so that you're notified every time we go live so that you don't miss opportunities like this. At some point, as you know, we're going to offer up the chat room and take your questions live. But I wanted to let you know, so this is a first again. This conversation is going to be primarily about aortic dissections, although if you have another form of aortic disease, this is for you to also pay attention to, right? We want to steer away from this, but this is going to have some really good information that you might want to stay tuned for. Today with us, we have a very special guest. It's Dr. Charles Roberts. And Dr. Roberts is a cardiovascular surgeon at Baylor University Medical Center in downtown Dallas. He's the chief of cardiovascular surgery there, and his expertise is in aortic surgery, particularly the treatment of aortic dissection. And he's written extensively on this subject. And again, as I said, today we're going to talk about aortic dissection. So welcome, Dr. Roberts. We're so excited to have you.
Well, thank you, Karen. It's lovely to be here on this Monday afternoon. No, it's Tuesday, Monday afternoon.
No, it's Monday. I did the same thing.
The,
It's that Thanksgiving. It
That's
screws
right.
everything up, right?
It's lingering. Well, it's a pleasure to talk to you all today. And the aorta is a big subject. I think of it as a candy cane. And I think of surgery on the aorta as surgery on the candy cane. And what I'd like to do, if I may, is focus primarily on dissection. But at the end of it, I'd be very pleased to take any questions. But when I talk to patients, often if I carry a candy cane in my white coat and just say, okay, this is the aorta. Now, I'm typically interested in the first part, the ascending part of the aorta, and cardiac surgeons tend to treat the first part and the arch, and vascular surgeons are pretty heavily involved in the descending aorta. And we have a new sort of zone system where the whole aorta is marked out by zones. And zone 0 is my primary focus today. This is another picture of it, and you can see it's sort of shaped like a candy cane and goes all the way down the back. And the first part, the ascending part of the aorta, is called zone 0 in our medical literature. DeBakey had a huge impact on aortic surgery, he and his colleague Denton Cooley. And one of the early classifications was called the DeBakey classification of aortic dissection. And he divided into 1, 2, 3. And 1 and 2 involve the first part of the aorta. 1 goes all the way down the candy cane, and 2 just stops at the first part. And DeBakey type 3 just involves the descending. Now, the more commonly used classification now is Stanford A and B. And A just means the ascending aorta is involved. And so Stanford A would be DeBakey 1 and 2. Mm-hmm. Whereas Stanford B would be DeBakey 3. But okay, most of the time we use A and B now. This is the catastrophe of acute aortic dissection involving the ascending aorta. This is a beautiful medical illustration by Leon Schlossberg, and it shows the pericardial sac around the heart, but the sac also incorporates the ascending aorta. So when you have a rupture of the ascending aorta, it fills the sac around the heart and it compresses the heart. And that's usually, the cause of death when somebody has a rupture of an acute aortic dissection involving the ascending aorta. Now, this is a picture from pathology. What dissection means is that it splits the wall. The wall of the aorta is dissected, it's split. And this is a cross section of the aorta from down on the downside of the candy cane on the back. And if you just cut across it, this is what it looked like in one patient. And it usually has a true lumen and a false lumen. And the true lumen is open in this patient. The false lumen is full of clot. But that's what happens with dissection. You have an entrance tear, and then it splits the wall going forward and backwards into two lumens, true and false lumen. And this is the three arch vessels, the three blood vessels that come off the arch. And you can see how this third branch here, I believe this is the innominate artery, the first branch actually, and it's split into two channels. So any branch of the aorta can be affected by dissection.
Mhm.
If the aorta is dissected, the dissection can go out onto the branches too. So every organ is at risk, really.
Right.
Now this is a picture from surgery, and it's from the surgeon's angle looking at it. So it's on the right side of the patient, but you see the aorta coming up out of the heart, and this is a kind of a mild looking dissection actually, but you can see the bright red part. That represents a dissected aorta. And our treatment is typically just simply to replace it with a tube graft, which is made from a material called Dacron. This is another dissection looking at it from the surgeon's side, and you can see how purple and abnormal that looks. It's really on the verge of rupture. And
These look large to just a person like me, who's not really seen many pictures, actual pictures. I'm used to looking at illustrations. What were we looking at when it came to width-wise of that graft? Because it just looked enormous.
well, usually in the native aorta,
Hmm.
if the original aorta is under 4 centimeters, that's generally considered normal.
Okay.
But when dissection occurs, it actually enlarges about 20% just with the
Okay.
event. So
Hmm.
this looks, this is larger than it would be the day before the dissection.
Okay.
But still in general, and in this patient, I'm sure her native aorta was over 4 centimeters and therefore enlarged.
Hmm.
And then we put a tube graft in like that. And our goal with the tube graft is to remove the entrance tear. And the entrance tear is usually in the ascending aorta. And then we
Hmm.
replace the ascending aorta. So tamponade or rupture is not a possibility anymore. Now, the descending aorta is usually treated differently. The downward part of the candy cane, that's usually treated with stents. And this is a picture of a stent going down the, the descending aorta. And the reason we do that is because when you've got two lumens, sometimes we let them heal on their own. But if the false lumen is pressurized, it can expand over time. And that's why we follow people in aortic clinics to measure the diameter of the aorta after a dissection. This would be a type B, meaning
Hmm.
it's just the descending. And often we just let them heal. However, we follow them in the clinic with CT scans. And if it gets too big, we'll put a stent in. And that's kind of what this looks like. If you put the stent in, then the false channel sometimes just turns to clot. Back in the day, in early, when people did surgery for dissections, the mortality rates were very high. And this
Hmm.
was a Stanford series. I'll give you an example. For example, if we do a coronary bypass, the risk of death is about 1%, 1 to 2% max.
Hmm.
You compare that to an aortic dissection operation, and particularly back, before 1980, I mean, these were very high mortality
Yeah.
rates. And today, a lot of us submit our data to this big registry, and the mortality rates today are lower, but they're still very substantial. I mean, they're 10 times, repairing a type A dissection is 10 times the mortality rate of a coronary bypass. So
Yeah.
it's still a very formidable kind of surgery. Um, this is just a little bit of, why does a dissection occur? Generally, everybody has high blood pressure, but there's some conditions which are predisposed. We all know about, the connective tissue disorders like Marfan syndrome, but there's also patients with bicuspid aortic valve. The aortic valve is supposed to have 3 leaflets, and occasionally 1 in 100 have 2 leaflets, and
Hmm.
they're at a little more susceptibility to dissection. Um, this is my series in the past 6 years, and all dissections are not the same.
Hmm.
A
Yeah.
spontaneous dissection means it just sort of comes out of the blue. And if it's happened within 2 weeks, that's considered an acute
Hmm.
dissection. If it's happened 2 weeks and beyond, it's considered chronic. Now, there are a lot of people that have had previous aortic manipulations. Let's say they've had a cardiac surgery, or they've had a stent placed somewhere, or a cardiac catheterization. And sometimes those actual procedures can cause a dissection. So they're kind of in a separate group. If somebody's had heart surgery and they get a dissection later, that's not the same patient as somebody that was fine, no previous chest surgery, and then suddenly has a dissection.
Hmm.
All those patients spontaneous, and the other
Okay.
ones iatrogenic is the word we often use. Um, this is a typical dissection, and this patient came in yesterday,
Mm.
and she was 73, and she slumped over in the morning and felt what she described as an explosion in her chest. And that's the word she used, explosion.
Yeah.
And it turns out that she had a tear in the ascending aorta with dissection going forward and backwards, antegrade and retrogradely. And she actually ruptured. Blood entered the
Mm.
pericardial sac, but it sealed off. So she survived,
Hmm.
came to the hospital. We took her to the operating room, and we replaced the ascending aorta. That's a very typical operation. The black part is where you kind of insert felt between the layers to bring support, and then you sew a tube graft uh, in there. And in this case, it's a 3 centimeter or 30 millimeter graft. So that's a very typical operation for dissection. This is another one. Um, the picture on the left is what we faced, and then the picture on the right is what we did. And this patient had an entrance tear just above the aortic valve, and that is very typical. That's the most common site of an entrance tear is just above the aortic valve, and it shears the artery, the lining, and then the wall splits,
Hmm.
going forward and backwards. And so in this case, the felt is green, and you kind of slip felt between the dissected layers and put bioglue, and you kind of bring the 2 layers together for support, and then you sew the bottom end and the top end, supported with felt as well. And in this patient, she didn't rupture externally, so there was
Okay.
no blood in the pericardial sac. Now this is another patient that came in shock and had an entrance tear just above the aortic valve, very typical, had a separation of the wall, dissection antegradely and retrogradely,
Hmm.
and this patient ruptured outward. And so the whole sac was filled with blood. The patient's heart was compressed and was not able to fully expand. And the patient was in shock and
Hmm.
actually coded in the emergency room and was very acidotic and this kind of thing. And those are very dangerous situations. And when there's, we call it tamponade, when
Hmm.
the sac around the heart is filled with blood and compressing the heart. This is another one where there was clot in the false chamber, The entry tear was also above the aortic valve, but the false chamber actually filled with clot. Sometimes those are not within 2 days. Maybe they're 10 days out, and clot
Mhm.
has time to form within that false channel. But the treatment is more or less the same. This is one where more was required. The tear was in the almost at the arch, um, but not quite in the arch, and the dissection went both ways,
Mm.
antegradely and retrogradely. There was no rupture outward. Um, but this patient, this retrograde dissection just sheared off the origin of one of the coronary arteries. The two coronary arteries come off the aorta, and sometimes that dissection can rip down the aortic wall and then shear off one of the coronary arteries and cause a heart attack together with the dissection.
Mm.
In this case, I just tied off that artery and put a bypass to it and replace the valve because it's all down there and it's just simply too hard to repair everything. Now, sometimes people, when they're older, let's say over 75 or over 70, they sometimes get calcium in the aorta. It's much like atherosclerosis.
Mhm.
And when you get calcium, it can actually serve to stop the progression of a dissection. In other words, you can have an entrance tear just above the valve, and then it goes antegradely, but then it hits calcium, and it sometimes will just stop cold. And this would be called a DeBakey 2. It just involves the ascending aorta. But usually those DeBakey 2s, they stop because of calcium. So
Mhm.
the patients tend to be older. If somebody's 30 and they have a dissection like this, it can go all the way down the candy cane.
Mhm.
Nothing stopping it. Whereas if you're 75 and you've got calcium in the aorta, sometimes it goes and just stops where the calcium is. That's very typical.
Mhm.
Treatment's more or less the same, replace the ascending aorta. Now, the worst place to have a tear, that is to say an entrance tear, is right on the top of the arch there, because that makes things very complicated. It means you've got to,
Mhm.
replace the arch because you see the three branches going up.
Yeah.
That's very difficult to treat with just a simple graft. You,
Mhm.
you got to address the branches. So that this is called an arch replacement, where you extend the graft up, maybe up to the last branch of the arch, and then put bypasses to the first two branches of the arch. That always means a longer operation, and that's let me see. Okay, there's a new device called a Thoraflex graft, which when you have to deal with the arch, it actually comes in one piece.
Mhm.
So you've got the graft that you sew in, and then you've got a part, it's a stent part that you stick in the downward part of the candy cane, but it's all one piece.
Mhm.
And that's called a Thoraflex graft. And we use those for very, specific indications, particularly if the arch is involved.
Right.
It's a longer operation.
Yeah.
This is another example of a Thoraflex where, you see where that entrance tear is? That is right at the top of the arch. That's the worst place to have the main entrance tear because when you see that, that means you've got to replace the arch. And that's a bigger operation than when the entrance tear is just above the aortic valve. That's the Thoraflex
Mhm.
graft that I was speaking of, and that's would be considered an advance.
Mhm.
Um, Now, dissections, sometimes people have had previous operations and then they get a dissection. This patient had a previous aneurysm and had a graft sewn in and then developed an acute dissection in the arch portion later. And in this case, we used that Thoraflex graft to replace it. And just sewed it to the previous graft. And the brown is the endograft part where you slip it inside. Now, this is another example where I have shown this, but where when this entrance tear involves the arch, it's a bigger deal.
Hmm.
First thing I look for when I open the aorta is where is that entrance tear? Where's the beginning? Where's the initiating tear of the dissection? And it's always nice when it's just above the valve because it usually means you don't have to do anything in the arch. But
Hmm.
when the tear is up in the arch, the entrance tear, that's a more formidable situation. Do you know what? I think that's the last one. Um, so I was going to say that I've really focused on aortic dissection, um, but I'd be happy to discuss, causes and surveillance and those kind of
Yeah.
things.
I am so struck by that. I was going to first ask you if you have a candy cane in your white jacket that you're wearing right now.
Yeah, right
'Cause
here.
you said you carry them in your white jacket. See, there it is. All
There's
right,
the
well, then check.
yeah.
The graphics were amazing. Thank you so much for showing that. And the one that struck me the most was when somebody has an aneurysm repaired, and I think the fallacy is that they're one and done. And that's just the given, and that's just the way that it is. And I'm glad that you showed that, because sometimes people don't understand why they need to continue to be followed, or that they should be, and why they're monitored, and why all these, any, if you're on medication, why any of it's really important. And that's because it's still, you still could have a dissection. And we've had a couple people, someone on my board who had a type B, 10 years later had a type A. So, and then she was in the operating room. I mean, these things, they happen, including
Yeah.
people on watch and wait, and they're being wheeled in for their surgery, but they spontaneously dissect on the way to the operating room. The stories are just so wildly different. So I do thank you for showing that. And I have one question about true lumen versus false lumen. The very first picture struck me because the most open part was the false lumen. So how is it that people can, I mean, I'm living with it, so I don't know, but I think I want to know, how do people function and end up having this same circulatory system where they're able to use everything with this teeny tiny little spaghetti noodle area of blood that's flowing,
I know.
and the rest of it's all blocked. So it just doesn't, because we sometimes in the community will, oh, I can't really feel my legs that well. Things start playing with our mind because we're told this information. So how do we compensate? How does that work?
Well, initially, when the dissection occurs and it's created these two channels, true channel, false
Hmm.
channel. The septum between the two channels
Yeah.
is very dynamic. It's floppy.
Hmm.
So you catch it on a CT scan and it looks static. Like that's the way, and the true lumen looks maybe like a half moon, rather
Hmm.
small. And you're thinking, how in the world is that blood flow
Yeah.
going to these native arteries? Um, but the septum is dynamic. It's
Hmm.
flapping around. So in actuality, enough blood is getting there.
Okay.
Now, if you have a false channel that ends in a I'm not trying to say a closed loop, it just there's no place for it to go. You can often find clot build up in the
Hmm.
false channel all the way up. If you have a reentry tear, then the blood just keeps flowing through the false channel back into the normal channel. But
Hmm.
if it's an endpoint with no reentry tear, clot can sometimes build up and form like that.
Is that considered a good thing, a bad thing, an indifferent thing?
I think it's better, um, to have a false channel just clotted off
Hmm.
than a blood flow in it, because
Yeah.
what happens is the wall of the aorta, when it splits in the media.
Hmm.
Okay, it's the middle. There's intima, media, adventitious, and the split in that wall occurs in the media. But guess what? It occurs in the outer 2/3 of the media.
Hmm.
So the false channel outer wall is thinner
Yeah.
than the normal wall. It only has 1/3 of the media generally. So you'd
Right.
rather not have blood flow in it.
Yeah. Yeah.
Perfectly fine. But what we do is we follow people with CAT
Hmm.
scans over
Hmm.
the years, and we measure the full diameter of that artery. And if it
Hmm.
gets too big, we might recommend putting a stent in there.
You just said a magic word I want to talk about. Let's talk about CAT scans because what they say in the community is the big argument. We know the CAT scans are the golden standard, but why? What? So we also try to tell people make sure you have your tests at the same facility every time, where you're using typically the same machine. What is a gated CT and why should somebody be asking or making sure that they're having a gated CT?
Well, there's some CT scans like a pulmonary artery CT scan that they might
Hmm.
do in the emergency room,
Okay.
uh, that for looking for a clot, a
Hmm.
PE they call it, and
Hmm.
they don't address the ascending aorta very well. You can get a lot of artifact and movement, and the best CT to get is called a CTA, a CT angiogram,
Hmm.
and if the dissection of the abnormality is confined to the chest, well, you can get a CTA chest. But most dissection patients, we get CTA chest, abdomen, pelvis because we want to see the whole candy cane.
Right.
We want to see the whole thing, particularly, let's say you've had a Stanford type A dissection involved
Hmm.
the ascending aorta was replaced. The first part of the candy cane was replaced with a Dacron tube. However, the entire rest of the candy cane has just healed on its own.
Hmm.
But that's why we want to check it once a year and make sure the diameter is not growing, not
Hmm.
getting too big. But generally, you want a CT with contrast and what they call a CT angiogram.
Hmm. Okay. Because when people complain that they have last year's test said they were 4.4 and this year it's 4.5 and they freak out that they say they have all this growth, look it grew, and but we're unsure, did they catch things in a heartbeat? Is that
Yeah.
really growth? Can you speak to that? Like what is growth so that people can hear it and understand whether they're measuring, but it doesn't really matter, but when they come back with these measurements, what is typically growth?
Alarming growth would be 5 millimeters in 1 year.
Hmm.
Okay, not 4.8, 4.9, but let's say 4.8 to 5.3.
Three. Yeah,
Five
that would be
millimeters.
alarming.
5 millimeters in 1 year is considered, you know, red flag.
Hmm.
Mostly we look at thresholds. Now, I'll say that general thresholds for everybody is under 4 centimeters, normal, 4.0 to 4.9. We use the word ectasia. It's
Hmm.
a Latin word, it just means enlarged. And 4.5 or greater, we use the word aneurysm. The
Okay.
problem with the word aneurysm is it's so alarming to people,
Yeah.
that come to the clinic and somebody said they had an aneurysm and, they lose sleep about it. But it's really just a diameter measurement. But in general, 4.5 or greater, we start to use the word. The proper definition for aneurysm in the vascular surgery textbooks is simply 1.5 times normal.
Okay.
Whatever that artery ought to be, if it's 50% larger, it's an aneurysm. It just
Okay.
means enlargement. Okay. But for the aorta, we generally, but that's not broken down into male female.
Hmm.
If you have a 6'5" male compared to, let's say, a 5'3" female,
Hmm.
I mean, 4.5 is very different in both those people.
Right.
You
Right.
So
Exactly.
those general numbers really all have to be tailored or customized to the
Hmm.
body frame height.
Hmm.
Um, but generally, for the ascending aorta, we don't recommend replacing it preemptively or preventively unless it's 5.5 in a man.
Hmm. Okay.
Now, and perhaps 5.0 in a woman, but
Hmm.
there's some caveats to that. For example, if you have a connective tissue disorder, will drop that threshold. If you
Right.
have a bicuspid aortic valve, we'll drop that threshold. So in our clinic, we always want to know, is the aortic valve normal or abnormal?
Hmm.
Is the aortic valve at 3 leaflets or 2 leaflets? That's a very easy thing to determine on
Hmm.
ultrasound.
Yep.
And the other thing we want to know is there any family history or connective tissue disorder that we're dealing with? Because that would um, that would get our attention. We would consider a preventive operation sooner
Hmm.
than the normal criteria. Remember, replacing an aorta or a portion of the aorta for aneurysm is purely a preventive operation,
Hmm.
and it has risks. So you have
Hmm.
to balance that. If somebody's 85 and their aorta is 5.6, I don't think we would operate.
Yeah. Yeah.
You
That
know,
makes sense. Yeah.
yeah.
Okay. Couple questions before I see who's out there and has questions. Only because it's now December and outside of where you are and people in Florida, it's cold. We were just talking about this before we
Yes.
went live, and we talk to people about not shoveling snow and you know maybe not exercising so hard out in the cold weather. And for some people, it's a big shock to the system when they walk outside, especially if they're not wearing a scarf. What exactly does the cold weather do to our vascular system?
Well, that's a very good question. I think in general, you get constriction um, rather than dilation.
Mhm.
Um, when you exercise, your arteries, in general, your arteries dilate. All the arteries, they just dilate a little bit. When you smoke a
Mhm.
cigarette, they constrict.
Mhm.
Cold weather, I'm not an expert on this, but I would imagine cold
Okay.
weather, they constrict.
Okay.
And uh, I'm not aware of any studies that show cold weather versus warm weather and dissection. It'd be interesting
Okay.
to look that up.
Yeah, we've tried to take polls, and it does seem like more people have dissections in the fall, winter months, which is,
Yeah. Yeah.
a crude survey that we did. So it really wasn't anything special scientific, but just asking around, it just seems like that tends to happen. And I wonder if that's the same months that heart attacks happen in, just overworking the heart, maybe.
Probably so.
Yeah. Okay.
Probably so.
Yeah. All right, here's a silly one. It's not so silly because after you've had a dissection, you get scared to fly, and everybody's going to start traveling to see their loved ones now. So explain why flying might be okay, barring any blood clot issues that people might have.
Well, a dissection, let's say you've had a type B
Mm-hmm.
dissection and nobody operated. They just said, we're going to let it heal.
Yeah.
Okay, healing takes 2 months
Mm-hmm.
for scar tissue to form. So
Okay.
generally, dissections are healed at 2 months. Now, let's say you had a dissection that involved the entire candy cane. They just replaced the first part.
Mm-hmm.
So the rest of the aorta is just healing. In 2 months, it's more or less scar tissue.
Mm-hmm.
Generally, travel is okay after 2 months. Same with heart surgery.
Mm-hmm.
But generally, it's okay. I mean, what if I had a dissection? Let's say I had a type B, and they said, okay, it's not dilated. You had no serious malperfusion.
Mm-hmm.
We're just going to let it heal. I'd say, okay, fine. Well, I would stop weightlifting. I
Right.
would convert over to aerobic activities.
Mm-hmm.
I probably wouldn't suddenly go out and shovel snow. I'd probably get my son to do it.
Yeah.
Um, I
Exactly.
mean, there's some things I would do to not have tremendous spikes in blood pressure, shall we
Yeah.
say?
I
You know,
probably would stop roller coasters.
yeah,
I might not skydive, not that I would have before. But these are all the questions the community wants to know. Can I scuba dive? And everybody's like, No. But there are some people that work with their doctors, and I guess when the time's right, they do. I mean, I can barely be in a pool. Once I hit 5 feet, I can feel it in my chest. Like I can feel the
yeah,
pressure. So I think everybody's different, but I knew that flying generally is going to be
it's
okay as long as you're recovered.
definitely.
Yeah,
But I do bulk weightlifting. I convert
yeah,
to light weights, repetition. All
right,
these things would be just very sensible
right,
changes.
sure.
Because you don't want to put stress on the residual dissection, whether
Yeah.
you've had a previous, short graft in the ascending or whether you've had
Hmm.
a type B that was not operated on. Any residual dissection in the aorta, you'd want to keep your blood pressure I would prefer 130 or less on the blood
Mhm.
pressure
Mhm.
thereafter.
Mhm. Okay.
It-
All right. I'm going to check in with Josh and let's see who's with us today. I'm
All
not
right,
sure if
I'm muted a
okay, there you
bit.
are.
Here we are.
That's okay.
Doctor, thank you so much. You've been great.
oh, thank you, Josh.
Right away, we're going to say hi to some of our regulars, Velda and Natalie. We have a new person, somebody that you might be familiar with, Doctor Christopher Mouse.
Oh, yes, my good friend. Yes, sir.
He says, Dr. Roberts, it was wonderful hearing you speak. This is Christopher Mouse. Do dissection survivors usually need follow up reconstruction / follow up surgeries?
Well, it depends, how extensive the dissection is, age, a lot of variables. If the dissection involved the entire candy cane at a young age and just the first part was replaced, more than likely something's going to be necessary over the lifetime of the patient. If the dissection was confined to the ascending and the aorta was replaced, then really the answer is no. No further treatments necessary. It kind of depends individually. Type A, type B, age, this kind of thing.
Okay, but what do you define as young? That is a question I must know. Because I had a type A all the way down. So that's why I'm asking. I'm coming up on my 10 years. So was 45 young or was 45 not young?
Very young. Uh,
Okay, well there you go. Just
Now, I would
that's a good
say
answer.
that
Yeah.
you'll probably go your whole life without needing anything more,
Hmm.
providing that you keep your blood pressure 130 or less,
Yeah.
get that annual CT, measure diameters, and and avoid those kind of Valsalva exercises where you spike the blood pressure.
Right.
Yeah.
Absolutely. I hear you.
Right on. And so, as we're getting through your presentation, Velda comments, Natalie, look at that aorta.
I did the same thing. My eyes
Popped.
like, wow,
Yeah.
that's pretty big.
Natalie was like amazing with the star smile
Hmm.
emoji. And then, uh, and then Chris once again chimes in. He says, Dr. Roberts is great. He did numerous follow up surgeries on me. I love this guy. And we responded, he does great work.
That's very kind of him.
All right, so Natalie says, question for Dr. Roberts. What are the stats around reoccurrence of dissection type A in descending or type B amongst people that had a previously type A dissection in the ascending?
Well, that's a very interesting question. You, there are people that have had a type B, which just involves the descending aorta, who come back, you know, within 10 years, say, and have a brand new type A. Now, the there's some caveats to that. Let's say you had a stent put in the type B, and there's a new entrance tear adjacent to the stent. Well, that could be related to the stent.
Mm.
Or you could have, we did a paper on this. I think we had about 10 people that had a type A after um, a type B treated with stents. And you can have a fresh new entry tear just above the aortic valve, which is unrelated to the stent. So if I had a type B, I would just do my best to keep my blood pressure, under 130. Because
Hmm.
in general, when I'm called to the emergency room to see a patient with dissection, almost inevitably the pressure's over 160.
Oh,
I mean,
wow.
it's basically a hypertensive disease
Hmm.
with certain predisposing groups, like bicuspid aortic valve or connective tissue disorder. But it's basically, 95% of people have systemic hypertension.
Okay. If you had a type A all the way down, could you have another dissection? I mean, even assuming that you're keeping your blood pressure. I mean, I guess I never really thought about that you could have another a tear someplace else. I guess it could happen, right?
Yeah, it could happen. Kind of rare
Outside of
because
the
it's now
graft. Yeah.
scar tissue, so it's kind
Right.
of odd. But I have seen Ascending aortic dissection. So let's say I
Hmm.
open the ascending aorta and I look. I have seen old tears that
Hmm.
healed adjacent to a fresh new tear. So people can actually, I know, people can actually have a type A aortic dissection or an intra-tear that heals and they survive it. And maybe they
Hmm.
thought they had chest pain and it just went away.
Right.
That's not that unusual. So the body has an amazing ability to heal things,
Yes.
even
Yeah.
though we don't know they're happening.
Well, and that makes sense because not everybody feels a ripping, tearing explosion. Sometimes
That,
people think they just have reflux. And I don't know why there are people like myself who lost sensation in their arms and legs briefly, although that briefly felt like it was forever. I mean, literally like nerve block and you're just a stump. But I thought it was that I had gas that I had bowel resections before that for Crohn's. So
yes,
I thought the gas left an anastomosis and landed on my spine. That's what I told the 911 operator because it made complete sense to me. I would never thought that this is what it was. Even though
but
my
it's
father had an
interesting because
abdominal
it,
aneurysm,
mm,
who would have thought this? You don't think this, you know? I just had gas on the spine. It made total sense to
yeah,
me, you
yeah.
know. But so not everybody, so there are some people I know that had dissections that just felt off. They just felt a little dizzy, like instinctively knew something wasn't right. Um, and then there are people, we had another board member who was in the middle of treatment, chemotherapy for breast cancer, and felt that same burning down her throat. And they just assumed because she had did some running before, she started her chemo, that it was an esophagitis and just sent her home. But 2 weeks later, the pain got worse. And that's when they discovered she had a type A dissection. So,
It's
sometimes you're
very
sent home.
often misdiagnosed.
Yeah.
It's a highly litigious area
Yeah.
because people come into the ER, they've got chest pain, they're ruled out for a heart attack,
Right.
perhaps sent home. Nobody got a CT.
Yeah.
So it's a that's why, the think aorta and be aware of it in the emergency room
Right.
is particularly important.
Ask the questions, check
Yes.
the pulses. Yeah. Yeah.
Yes.
Okay,
Okay,
Josh.
right on. And so let's see here. Follow up question here from Natalie. Is it common to have repair on the ascending and hemi-arch instead of a repair of ascending and total arch?
Yes, it's most common to replace the ascending aorta and then the first part of the arch. In other words, you kind of make an angle down from where the first branch comes off, kind of an angle down toward the middle. And it's most common not to do a total arch
Hmm.
because it's such a formidable operation. I mean, you're adding an hour and a half. It's more complicated. You're clamping blood vessels. The most common operation is replace the ascending aorta and then
Hmm.
what is called the hemi-arch, meaning uh, proximal arch or first part of the arch, but not involving the three branches.
Okay.
You kind of make this angle.
Are
Um,
you involving even the first branch or not even? You
Not
just
even the
literally
first
stop.
branch.
Okay.
Let me go to my slide for a second. I'll show you what that means. It's a funny
Okay.
word, proximal arch,
Hmm.
but it kind of means, let me go back a couple slides. Oh, it kind of means, you see that where you're not really replacing the arch, but you're doing this kind of angle.
Sure.
That's what a it took me a long time to understand what it meant too, but it just means hemi versus complete. You're kind of
Hmm.
doing this angle, but you're leaving the branches intact.
Okay.
That's what most people do. And Denton Cooley was responsible for to do that connection, that anastomosis. You basically have to stop the circulation.
Hmm.
That's why people call it rest,
Hmm.
circulation rest, to stow that one. And that's the most, this operation right there is the most common operation done in America for this disease.
Hmm.
You do, you replace the ascending aorta and then you sort of cut into the arch a little bit at that angle. And that's called a hemi-arch.
Okay.
But doing a total arch is a bigger deal.
Yeah.
A total arch is that.
Yeah, that's a big deal.
Yeah.
That is a big deal.
they're in the ICU longer, everything.
Yeah. Yeah.
So
Okay. Good follow-up question, Natalie.
yeah, that was.
Right on. All right, so let's see here. Is the MDCT scan any better?
MDCT.
Hmm.
Uh,
What is that?
MDCT. I'm not sure. It's a question
I'm
from
not sure.
Chris.
That's a new one for me.
Multi-dimensional, maybe. They can do incredible things now with CT scans.
Mm-hmm.
Spin image, so you're looking at the candy cane from all different angles. I mean, the technology is extraordinary. And we have an aortic aortic conference every Tuesday morning, and we always have a radiologist there that
Mm-hmm.
they're incredibly sophisticated about, spinning and creating 3D images. So when we go to the operating room or post-operatively, we can look at just incredible images.
Have you started in with any VR in virtual reality going through people's aortas from the inside yet?
Not yet, but I know
Okay.
that's coming.
I got to see an example of it. It was kind of
Did
fun.
you?
Yeah, on
Oh,
my own. On my own. Yeah, my cardiologist took me through, and yeah, and I learned a lot. I think she learned a lot in that moment too that we didn't know beforehand because we saw it from the inside. So we had to do a lot of. I'm going to talk to you offline type of things because there was never told that any part of the carotid was involved until we saw this scan from the inside, and we both kind of just looked at it. It was very interesting, but it was only just a short portion, but it was still cool to go. It was like
yeah.
what is that? That movie where they go into the body. I can't remember what it's called. You know the movie I'm
I know
talking about.
exactly what you're talking about.
You know which one I'm talking about.
Vascular surgeons are very skilled at putting ultrasound up into the aorta and investigating, where the tears are and all this kind
So
of
cool.
stuff. Yeah.
Yeah.
There was
What
a
else?
surgeon.
I was going to say, what else is anything else on the horizon? Because we do hear about a couple different things that could be coming out. I mean, we're aware of the Impact AD study that's going on right now for determining or hopefully determine if a TVAR is maybe more effective than medically managing a Part B. And, I've heard a bunch of different things. A lot of it has to do with abdominal. Anything that could be happening on the horizon to address, the
Yeah.
ascending or
Yeah,
thoracic area.
the big challenge is that most dissections are ascending, the majority. And that generally requires diverting the circulation on the heart-lung machine. It involves stopping the circulation to sew the graft in. And so if there's a way to do it by endovascular means, that would be ideal, but it's very, very complicated. And you've got those two coronary arteries coming off that nourish the heart. So you've got to deal with those. But there are trials going on now for stents in the ascending aorta in patients that are not considered operable candidates. Maybe maybe they're too old or stage 4 cancer or something. And you say, okay, well, we'll just try putting this stent in. It's experimental, but it's being done in America in trials.
Interesting.
Yeah.
That's interesting. Hey, at least it's something, right? Something to try to reinforce.
Progress, yes.
Yeah. Okay.
Okay, we have
All right,
just a
Josh,
couple more
how are we
here.
doing? Okay.
Let's see. Natalie says, another question. What are the real risks of not taking beta blockers after an acute type A dissection in ascending aorta? I was taking a microdose and now I'm on a trial period without the beta blockers.
Well, beta blockers reduce the force of the blood hitting the aorta. And I'm a fan of beta blockade in all patients with dissection. And I know it has some side effects here and there, but if I had an aneurysm that I was following, or if I had had a dissection, I would put myself on a beta blocker just for protection. And that's what they call the force of the heart beating against the aorta, and it lessens that a little bit. And also, lowers the heart rate some, but beta blockade, if I'm not mistaken, is really the only medicine so far that's shown to kind of lower the risk of dissection. So if you have an aneurysm, I would take one, and if you have a type A that was treated just the first part, and you've got a residual type B, I would take it. If you had a type B that wasn't treated, there are very few situations in which I would not take it.
Right.
And I'm always puzzled why sometimes patients will come to clinic and they're on two different antihypertensive agents, and neither is a beta blocker. So we tend to get a hypertension consultation in all our patients with dissection, and our go-to is carvedilol twice a day. But there are a lot of options with beta blockers.
Right.
Thank you for that, doctor.
You're welcome.
All right. Things that we were questioning, activities. Chris says, how about skiing, with a big laugh emoji? Yeah, I cannot wait for you guys to hear Chris's story. I've already had an opportunity to hear. It's going to be a great. He's scheduled for the 14th of this month. Yeah. Natalie, question for Dr. Roberts. I read on my repair type A ascending and hemi-arch that my 3 upper pipes were infiltrated. What does that mean? Guess they were not teared because they didn't do anything about that?
Well, it means that they did the standard operation for a type A, and it probably means that the entrance tear was just above the aortic valve, which is the usual spot, and then they removed that, they put the tube in, and the dissection itself, which means splitting the wall, can go all the way down the candy and it can go out branches. So it probably went out the 3 arch branches, but it doesn't mean you bypass them. It doesn't mean you have to go in and do something. As long as you remove the entrance tear in the ascending aorta and direct all the blood into the true channel tube, then everything kind of takes care of itself. Because you can't replace the whole aorta. You can't replace every branch that's got a dissection in it. Dissection doesn't mean obstruction necessarily. It just means that the wall split, but it does heal. And so I suspect what happened in her case was she had a type A with an entrance tear in the ascending aorta. A tube graft was placed, but the dissection itself had gone down the aorta and up the arch vessels. But it doesn't mean they had to be replaced.
Thank you, doctor. That sounds very comprehensive. Chris wanted to clarify, multi-detector computed tomography scan, MDCT.
Yes. Well, the progress in imaging just keeps going, and it's far beyond my understanding to keep up with it. But our standard, CT scan is CT angiogram, and I'm pretty sure it's state of the art. But I can't comment on the levels of quality, really.
If you can't do your standard CT because you're allergic, I have anaphylactic allergicness to that dye. I usually get like a cardiac MRI or an MRA, and you're just in there for 45-minute little snooze break to do the whole thing. And because I save those CTs for the ER. Because you're still going to wait about another hour or so to 2 hours. Some hospitals held me for 4 as I go through the pre-medication. So there's options. And if you ended up having to have an MRA, then the result will still be fine for the physician to look at.
And the main thing we look at for residual dissection that's healed is really diameter. And you can measure diameter without dye.
Right.
So you can still get information if let's say your kidneys are in trouble or you have terrible allergic reactions. A CT scan without dye still gives very useful information because you can measure the diameter all the way down the aorta without the dye.
Okay. Well, that's quick.
When
That's
I
good
do
to know.
aneurysm surveillance of the ascending,
Right.
I may get the initial one with dye, but after that, I'll just have people come back with CT chest no contrast.
Yeah.
And then I can easily measure the ascending aorta
Right.
diameter without it.
Right. Okay.
Yeah.
Good to
That
know.
is good to hear. Yeah, I hear that in the support groups quite a lot, actually.
Mm-hmm.
And so I do have a couple of anonymous questions that have come in here. Natalie says, "Thank you so much, Dr. Roberts."
Oh, you're
Um,
welcome.
the first one here says, "What does infiltrated vessel mean?" I read that the surgery report about the 3 pipes. Oh, I think Natalie just asked this question.
I think they meant dissected, not necessarily infiltrated, or the dissection extended into the arch vessels
Mm-hmm.
is probably what they meant instead of
Yeah.
infiltrated.
Okay.
That's what it sounds like.
Yeah.
All right, and then I think somebody might have asked this from our last Q&A, and I want to make sure that somebody knows an answer to this. This is a pretty simple one. Sometimes I get pain in the shoulder blade and armpit regions. What could that be? And this would be a post dissection repair.
Well, that could be just musculoskeletal chest discomfort from having, a median sternotomy, an incision in the chest, and it disrupts a lot of the musculoskeletal part of the torso. It may have nothing to do with your aorta. And one thing about, if you've had an aortic dissection repair in the ascending aorta, everything is scarred in after that.
Yeah.
So the risk of rupture in that first part of the candy cane is very minimal. I mean, because everything is scarred in, and you've got other layers of support. The pericardial sac is now draped over that, and so I doubt it's an aortic issue if you've got shoulder and side pain after that.
If it's immediately after, my guess, although I'm not a doctor, would be, if it's an emergency, they throw your arms out so fast,
Oh
right?
my gosh,
And,
yeah,
a lot of people end up with shoulder problems, frozen shoulders afterwards, just because
yeah,
nobody cares about the placement. They want to save your life. And I think also immediately after surgery, you still have a lot of air and gas in your body cavity. And so that stuff moves, you feel like you're having a heart attack, and you just gotta, if they say move your body, you literally need to move your body and walk around a little bit and get things going, and then just talk to your physician about discomfort. But it's really hard for us when we feel these little pings and pangs to not think, there is this happening again, because the gas pain will mimic sometimes the pain you felt, and so it's a mind game. And I always tell people to try to get that plan with your doctor. Like, if I feel this, at what point should I pick up the phone to you, or what point should I be going to the
yeah.
ER? And you have your game plan based upon your personal medical situation. But it's hard, and a lot of it is up here too. It's hard not to worry.
The other thing is that a dissection, operative repair of dissection, is and the event itself is much more formidable
Hmm.
than, even a heart attack. And
Yeah.
if I do a bypass on somebody, I'll generally say, it takes 2 months to heal, but let's say 3 months of healing after a typical conventional heart surgery.
Hmm.
Dissection is 6 months
Hmm.
because the
How
event
much does your sternum take
well,
to?
the breastbone generally takes 2 months to grow back
Hmm.
together.
Hmm.
But the event of dissection, the longer operation, the whole thing is about a 6 month kind of recovery, in my
Yeah.
opinion.
Yeah.
Just talking to patients, it's a bigger, formidable event. I would much rather have a heart attack than a dissection.
Right.
You know,
And I hate to say it, well, I wouldn't rather have it a dissection, but I have to say, having had abdominal surgery versus open heart surgery, I'd rather have my chest cracked open
yeah,
than
well,
have
there
my
are not as
stomach.
many nerves in the middle,
Yeah.
fortunately,
Yeah.
but it's still aortic dissection as an event, as a cardiovascular event,
Oh
is
my
more profound
gosh. It was
than
incredible. I mean,
yeah.
and we try to tell people 6 months minimal to a year, because I think it takes a while before your brain catches up and has time with that type of emergency to heal itself, before you can actually settle in and say, okay, this is the like 2.0 version, because your body just feels everything's sitting differently, and you need time to kind of get adjusted to this new body and being on medications, and it knocks you down. It knocks you
It's
down.
such a life-threatening event that all
Yeah.
that logically is, has an impact as well. All of it.
Right. Right.
Yeah.
Thank
Okay.
you for that too. Uh, Chris asks, can you speak to debranching? Is it related to what you just discussed?
Yes. Well, um, there's the total arch replacement where you put a graft limb to each of the three arteries. Okay, so that's one thing. But that debranching is typically meant to mean that you sew a graft from the aorta up to the innominate artery and another limb to the left common carotid artery and another limb to the left subclavian artery, and you staple off the origin of those three arch vessels. And so you bypass it. And then you come in later with an endograft and just cover the whole arch from the inside. So, in other words, it's a two-part deal. Part one is sewing bypass grafts up to those three arch vessels, and then using a vascular stapler and just stapling off the origin at the aorta. That's part one. And that's the part that I usually do. And part two is that vascular surgeons come in and slip an endograft across the whole arch, because now there are no branches anymore. The branches are coming off from a bypass lower in the aorta, so they're free to cover the arch. Right now, you can't put a stent in the arch because those branches go to the brain,
Right.
so you can't cover them.
Mm-hmm.
It would be a bad
Yeah.
stroke.
Right.
Deep
They're like
branching,
an off ramp from your main highway, and you can't just put up a barrier right there.
just you're from the inside,
Yeah.
or you'll
Yeah.
have a stroke. So a debranching means you do a preemptive operation where you bypass them from the lower in the aorta, and
Yeah.
the ascending aorta much lower. You do a bypass graft, and then staple them off where they normally come off, and then put a stent in to cover the whole arch. And that's done occasionally,
Mm-hmm.
really for arch problems.
It's
Thank
just
you
done
for that.
occasionally. It's no big deal. It's just a Thursday.
It's usually a
Um,
left kind of thing.
if I could, I would like to ask, how often do you modify medications post repair in those first few months?
Well, patients, you know, they're all on antihypertensive agents, and that requires follow-up, pretty steady follow-up by a primary care physician generally. What we usually do is give them a sheet with a date and a blood pressure, and we start them off and say, here's the date. I'm looking at your blood pressure right now. It's 160 over 90. That's too high. And if they're on a beta blocker, maybe I'll double it, or I'll make very minor modifications, and I'll send them home with that sheet and say, get 10 data points on there. So when you go see your doctor, they're not just looking at one number, they're looking at 10 numbers. But I try not to be the sole person responsible for the blood pressure, because that's an ongoing thing that it's better done by a primary care physician typically. But I like to see everybody on a beta blocker, and I like to see it 130 or less in general, the systolic blood pressure.
Okay, thank you for
Primary
that.
care or cardiologist, right? Or you can
Yeah,
have your cardiologist do that.
yeah.
Okay, thank you, Karen. Thank you, doctor.
We're good. All right. Well, I'm always amazed every time I talk with a doctor. I just think, what's going to be the thing I'm going to learn? And I cannot even begin to tell you how much I learned today. And just the pictures alone just really took my breath away for a minute. The way that you described everything and you showed everything, just even for me, I thought I knew Hemi-arch, but now I really know Hemi-arch. Like, now I've seen it, I get it, and it makes sense. And I really appreciate that. And I thank you for that, because if it's helping me, I know it's helping other people. And I appreciate your explanations and your answers to a lot of these questions as well, and your time in general.
I'm so glad, Karen. It was such a pleasure. I
It was
enjoyed
good
it.
to see you. It was good to see you again too. It's been a while, and I look forward to having you come on again. Hopefully, maybe we can do this like around September for AD month in 25. That would be great to
Yeah, maybe
revisit.
we can talk about aneurysms or something.
Yeah, that would be
Yeah.
wonderful. Yeah, let's talk about some aneurysms, or maybe I'll catch up with you in February. We'll talk about valve disease or something like that for that month as well. But just wanted to say thank you so much for joining us. And to everybody who asked questions, they were great questions. Thank you again. And please don't forget to click like and click subscribe and click that bell so that you're notified the next time we go live. And thank you guys again so much for a wonderful 2024. And I'm so happy we were able to close out my live events with you this year. And I look forward to what's coming up in 25. So thank you all again. Take care.
Thank you, Karen. Enjoyed it. Thank you. Bye-bye.